lot of late-breaking news out of this particular meeting in Orlando, and one of them is Resonate 2, which is coming up in the New England Journal of Medicine. It's online now ahead of print, and it's evaluating the safety and efficacy of Ibrutinib versus traditional chemotherapy as first-line therapy of patients with chronic lymphocytic leukemia or SLL, small lymphocytic lymphoma. And I'm with Dr. Alesssandra Tedeschi, who is an MD and Niguarda Hospital in Division of Hematology over in Milano, Italy. First off, thank you very much and congratulations. It's always fun to get something in the New England Journal of Medicine. In this case, Ibrutinib is a first-in-class oral approved for second-line treatment. So what are you looking at here?
The problem of elderly patients is that they poorly tolerate the more intensive immunotherapeutic regimens. So consider that Ibrutinib showed to be highly effective in relapsed and refractory patients. It is a very easily drug to deliver, it's an oral drug, and consider the safety profile, it would be that was a promising drug in the treatment of the elderly patients even with comorbidities. So what we did here is to compare and evaluate the value of the efficacy of Ibrutinib compared to Chlorambucil, which at that time was the standard treatment for elderly patients.
Now in this case, you're talking about people who are 65 or older?
65 or older, yes.
And how many patients did you look at and what did you find?
We looked at 269 patients. There were 136 in the Ibrutinib arm and 133 in the Chlorambucil arm. They were, of course, well balanced. It was a randomized study. And it's important that the median age of the patients was 73 years, so it was an elderly population, which is important in CLL because the majority of patients are elderly. And we looked first at progression-free survival. Patients were randomized to receive Ibrutinib 420 milligrams daily or Chlorambucil 0.5 milligrams per kilo, and the dosage could be increased if well tolerated, and up to 12 cycles. The primary endpoint was progression-free survival, and the secondary endpoints were overall survival, overall response rates, and of course toxicity.
So you ended up finding that Ibrutinib does seem to be superior to standard chemo.
Surely superior than Chlorambucil. Progression-free survival at 18 months resulted of 90% with Ibrutinib versus 52% with Chlorambucil. And also there was Ibrutinib had an impact on overall survival, was significantly higher overall survival in patients treated with Ibrutinib when compared to patients treated with Chlorambucil. There were, after 18 months of follow-up, 3 deaths in the Ibrutinib arm and 17 deaths in the Chlorambucil arm, with overall survival rate at 24 months of 98% with Ibrutinib versus 85% with Chlorambucil.
How about safety?
Ibrutinib showed to be safe even in the elderly population. Most of the toxicity were grade 1, nausea, vomiting, fatigue, and diarrhea, which is the major side effect, but it was of grade 1, and is in line what we have seen with Ibrutinib in other studies in CLL.
So where would this fit in now?
Well, it is important, this study, because it's one of the first steps towards a chemotherapy-free regimen. And this is important for elderly patients, not only for young, but mostly for elderly. They have many comorbidities, so immunochemotherapy may be too toxic for this population. And it would be important for these patients to receive a chemotherapy-free treatment as first-line treatment. And also what is important of Ibrutinib, that ameliorate the quality of life of patients immediately. And you cannot see the same thing with chemotherapy.
So anything else that you're looking at in terms of other studies?
Well, this opens a future on the treatment of chemotherapy-free regimens in CLL, but also in elderly patients. What has done now is to add monoclonal antibodies to Ibrutinib to see whether this may ameliorate the quality of response, because we didn't achieve a very high rate of complete remissions, even though maybe it's not important to achieve a complete remission, because progression-free survival is so good that this suggests that maybe achieving a complete remission is not necessary with these drugs. We don't know yet which is the value of a good quality of response like complete remissions with these targeted therapies.
So combination therapy may be next, is what
Maybe
you're saying.
next. But maybe Ibrutinib is enough itself. We never know.
Exactly. Well, you can see the results as they're published in the New England Journal of Medicine and at ASH 2015. I'm Rick McGuire.